I'm Director of IFIC's Country Hub in Scotland, and it's a great pleasure to be co-chairing this fantastic plenary on a subject that's really very dear to my heart and to our work with IFIC in Scotland.
Well, a good morning from me as well. On the second conference day of ISIC 23. My name is Isabel van Vrechem, and I'm the policy coordinator of Caring Neighbourhoods, and I work for the Department of Care for the Flemish administration.
So we have a very packed plenary session for you this morning, and the title, Engaging Everyone, really says it all. This is for everyone, and we hope that you'll be engaged and interactive and active online for those that are joining us hybrid. We've got two plenary speakers and followed by an interactive panel discussion. So it's my great pleasure to invite our first speaker to join us. We're absolutely delighted to have Dr. Kia Fortune with us. And Kia has had a prolific career with WHO in 3 global regions, most recently working with WHO Europe, and has got lots of experience and expertise in terms of public health, health equity and the social determinants of health. So nobody better to set off this plenary session and give us that global picture. Thank you, Kia.
Thank you very much, Anne and Isabel, for that very kind introduction, and good morning, colleagues. It's a pleasure to be here at this wonderful conference, and also I would like to thank the organizers for inviting the WHO to take part in this really, really important conversation. What I'm going to do over the next 10-12 minutes is that I'm going to highlight some of the global challenges that we face, and then also demonstrate how local and regional stakeholders are strategically addressing those challenges. So first of all, I'd like to take you back to 2015. So as you know, 2015 was a very historic year. It was historic in the sense that we concluded the Millennium Development Goals and the global community adopted the Sustainable Development Goals. It was an opportunity to take stock of the progress that we have made. And I think it's fair to say that there was much to celebrate. At that time, we saw an increase in life expectancy, a decrease in extreme poverty, as well as a decrease in under 5 mortality. But at the same time, there was a recognition that not everybody had benefited equally from this progress. And we know that poverty and inequity continue to be 2 of the greatest challenges of this century. And just to give you an example, we know that the gap between those who have and those who have not continues to widen. And unfortunately, this has been exacerbated as a result of the COVID-19 pandemic. But just to share that if you are a baby girl being born today in Japan, you are likely to live 32 years longer than a baby girl born today in Mozambique. We also know that place matters. So that inequities don't just exist between countries, but also within countries. If you look at this metro map that I have put up here on the screen, you will see that I used to live in Washington, D.C., and that's why I'm very fond of this metro map. But you will see, and I used to commute on the Red Line, you will see that within 17 stops spanning over 30 miles, you have an estimated difference in life expectancy of 9 years, and that's just within that red line. So again, I think we need to bear that in mind because that, of course, matters in the conversation about communities and caring neighborhoods. If we zoom in a little closer to this region, I think it's also fair to say that much progress has been done, but we also face challenges. Now, today, 2/3 of the population in this region live in urban environments. We know that in high-income countries, 1 child in 5 live in poverty. And we also know that 1.4 million Europeans die prematurely each year due to polluted environments. Now, at the WHO, at the heart of our mission, it is, of course, to really transform public health in the future. And as such, we have set ourselves some very ambitious targets. And our strategic priorities is to, one, ensure that 1 billion more people will be benefiting from universal health coverage, that 1 million people will be better protected from health emergencies, and that 1 billion more people will be enjoying better health and well-being. Now, I work in the regional office of the WHO. We consist of 53 member states. We host 900 million people in that very region. And we have this 5-year plan, which is really our implementation plan of the 3 billion targets that I have just shown you. And at the heart of our mission is to really ensure that we leave no one behind. And to do that, we know that we have to address those inequities that are so stark in this region as well. So we have all these different mandates and missions, but what does that mean in practical terms? I just want to again go back to the story of Jana. Jana is a little girl living in this region, and throughout her life course, she has been in touch with the health system 3 times. She lives in an environment where that's heavily polluted, there's poor infrastructure, and she doesn't have access to her greens and vegetables. 3 times in her life, she has been in touch with the health systems. Every time she has been treated, and every time she has gone back to the environment that made her sick in the first place. And this is, of course, what we would like to change. And increasingly, there is a recognition that if we want to change it, we have to do things differently. And in 2021, during the 10th Global Conference on Health Promotion, more than 5,000 participants from across the globe came together and they agreed to the Geneva Charter of Wellbeing. The Geneva Charter of Wellbeing is really building on the Ottawa Charter on Health Promotion, building on those lessons learned, but it's really fitting it into this century. And really importantly is that people are at the very center of this charter. And this is really what's guiding our member states in their work on public health. Now, I want to stress that it's really important that we are not starting from scratch. Much is being done. And I think it's fair to say that our local stakeholders, our regional stakeholders, they're leading by example. I have the privilege of coordinating the Healthy Cities Network in the WHO European region. And this is a network that was established over 30 years ago. In fact, we're about to celebrate our 35th anniversary. And it was established to put the Ottawa Charter into the streets of the people. It started off with 11 cities. It has since grown, and we now work with more than 1,400 cities in the region, in the European region. But we're also part of a global network, so we, of course, also work with the other 5 regions. So it's a very dynamic, powerful network, and central to the work that we do is what we refer to the 5 Ps. So our work is very much aligned with the Sustainable Development Goals, but we have added an additional P, which is that of P for place, because we recognize that if we are to transform cities, public health, we also need to take place into account. As a very concrete example, what the network is doing, I just want to draw your attention to the work that's happening around aging. We know that inequity throughout the life course, when they accumulate, they impact the way you enter into older adulthood. And that is, of course, we have evidence for that, and we recognize that we need to address that. As such, we have a lot of our cities are working to transform not just the environments, but also the way in which we engage with our older adults. In particular, during COVID, we saw very innovative examples of, again, really engaging with older adults, addressing that of social isolation, ensuring that they had access to technology. And it's just to say it was a really good example of how cities came together, learned from one another, and really transformed the lives of those older adults who were suffering during COVID-19. Another wonderful example, and you will be hearing that from our colleagues from Flanders and Brussels in a minute, is the work that we are doing with Flanders on caring neighbourhoods. We've joined forces, and here what's essential is that the Caring Neighbourhood Initiative is being rolled out in Belgium, and of course what's at the centre of this is that of health and well-being. It's addressing the life quality and ensuring that that caring neighbourhood component becomes an instrumental mechanism of this initiative. And again, I'm not going to steal the thunder from my colleagues, but it is just to say that it consists of 3 pillars and 8 building blocks. And again, the focus here is on participation and inclusion, connecting formal and informal care, and also really addressing that intersectoral collaboration, which is absolutely essential because we know that no sector alone can address some of these very complex challenges. And again, just to say, what does this mean in practice in terms of our partnership? It is really about making sure that we capitalize on these different networks that we have in place, making sure that knowledge is shared, not just within one region, but also above regions, making sure that we draw from the lessons learned from across the world, because we know that no size fits all, but we also know that there is so much that we can learn from others and that we can apply and adjust those. We also again, we have developed and are developing a toolbox in terms of the how-to. We often hear from both our member states but also our cities, we know what the issues are, but really we want to hone in on the how-to. And that's an absolutely central part of this initiative. And then again, of course, central to this is also making sure that caring neighbourhood is a key element in developing integrated care, and also, as I said, learning from others so that we learn from different stakeholders as we come to the table with different kind of expertise and different kind of experiences. So just to round up, I think what's important here is that the work that we are doing on participation and community engagement, it is transforming. We are seeing that there is a recognition from our member states that if we are to do things differently, we really need to hone in on well-being. Also recognizing that to do that, we need to learn from those local and regional stakeholders that have been doing this for a number of years and have a lot of expertise that they can share globally as well, so that we can let that inform our global policy making. It's also really important that we have this Charter of Wellbeing, because as I said, this is really what's going to, again, guide the work as we move forward, really putting people at the very center of all that we do and putting people at the center of our policies. And of course, in the future, what we'd like to see is for member states to really ensure that health and well-being is an integral part of their policy making, so that we ensure that we leave no one behind. And with that, colleagues, I would like to conclude here. Thank you.
Well, thank you very much, Dr. Fortune, and we'll remember that it's all about health and well-being, putting people in the center and leaving no one behind. Thank you very much. And we're also pleased to welcome Bert Donder here today to this plenary session. Bert Donder works as a policy advisor on caring neighbourhoods for the cabinet of Flemish Minister Hilde Krevits, responsible for welfare, public health and family. His background is in the field of general welfare work, poverty reduction, social policy, and, of course, caring neighbourhoods. But first, I'd like to give the word to Bert Donder. Thank
you. Welcome and good morning to all of you. In the next 15 minutes, I will try to give you some insights in the Caring Neighbourhood Initiative in Flanders, and so I prepared about half an hour presentation, and I will try to deliver it in half of that time as usual. I can give this presentation on behalf of our Minister Hilde Krevits. She was here yesterday to open the conference, and I'm very honored as well to be here to talk about our initiative to an international crowd. I'm as well very honored to talk after Dr. Fortune. Our collaboration with the World Health Organization means a lot as well. We think we can learn a lot from other countries, but as well are willing to share our knowledge and our experiences here in Europe and worldwide. Caring neighborhoods, or zorgzame buurten, as you can see on the slide. You already heard some of the information and even about our definition on Kira's slides. And I will try to give you some more insights on the policy perspective, the what, the how, and the why we are taking this initiative. I won't go into too much detail, but you don't have to despair. This morning already you could follow a workshop from Anne. You can visit, I think, the Caring Neighborhood in St. Andres. Isabel and Danny are giving a workshop this afternoon about caring neighborhoods, so we can go into further detail as well later with the panel. I will start by telling some of the main reasons we actually started with this initiative. And one of the main reasons, and it won't be a surprise, was COVID, Corona. There is, of course, a lot to say about this event, which affected our life. And it has put, as well here in Flanders, care and well-being to the test. We noticed that health and well-being, they seem allies to most of us, but they're not always. We had to isolate people in order to save their health, but which was bad for their well-being. So sometimes you have conflicts in between them. What was something we noticed? We had to sacrifice human relations, things like that. But it also learned us some important lessons. I think all of us noticed we are human beings. We need social contact in all kinds of ways. Small contacts of every day, talking to the bus driver or the cashier, as well as our family contacts, friends, care workers, and so on. We noticed as well that our neighborhood, our direct environment, became much more important all of a sudden. I don't know in the different European countries, but here at a certain moment, we could only take a walk in our direct neighborhood. We couldn't go far away from home anymore. So we discovered as well the value of our neighbors, of small things we could do for each other. Another big reason, and during COVID, we applauded every evening on our balconies in the city or in our gardens for the care workers. We noticed how important those former workers were for our system, for our health, for our well-being, for our society. But we also noticed that we have quite some issues on the labor market. It's difficult to find enough people to take care of all those needs. So we need as well those formal care workers, and we need to make them more happy, and we need informal support, care, little help, and stuff like that. We also noticed that the little helping of each other has more meaning actually than sometimes people think. Doing grocery shopping for your neighbor, and maybe that neighbor can help your kid with mathematics. That can really bond people together and can give a solution for one small practical problem, but as well can give a solution for problems that Kira also talked about, like loneliness and stuff like that. So COVID was more or less a spark we needed, but we also see bigger changes in society. Our families have changed. We have the most common household is just like mine, is a single person household in Belgium, which means you don't have direct help around you. You also live more often further away from parents, family, and stuff like that. we as a society need to answer that. We have those labor market problems as a major challenge in front of us. So the next question was, what should we do? And as policy makers, sometimes we do that. We go and sit around the table and we listen to people. Sometimes it was a virtual table, because we wanted to invest in those neighborhoods, which we rediscovered were important, and in that integrated, people-centered care, health, well-being. So we invited all kinds of experts, and some of them are also present. Some of them will join us later on stage, from civil society organizations, academics, local governments, and their representatives, people from different sectors in health and well-being, good practices. All those people, we invited them and asked them to talk about a subject like caring neighborhoods. Most of them already had certain initiatives. Sometimes they even called it caring neighborhoods. Sometimes they called it different, but they were working on those same subjects, on those same problems. And we wanted to tell them, why do you do it? How do you do it? What did you already experience that works? What doesn't work? And we learned some important lessons. And maybe the most important one was we need to tear down fences. We need to do that here in Flanders, but as well, I do think we will not be the only one. And the fences can be literal fences around our institutions of health and well-being care. Here in Flanders, we have lots of, for example, elderly homes, which are called forest rest or seaside, things that are quite remote, with a fence around, so people are nice and quiet and they don't get bothered by all what's happening around them. Which was, of course, done with a very good purpose, like, okay, people are old, it's a resting place, we need to let them rest. But you separate those people in need of care. We do the same with people with disabilities, stuff like that. We separate them from the rest of society. And it would be better to get rid of the fences, to get their neighborhood into the institution, and to get the institution out of the institution and into the neighborhood, and see how they can help to get better care and well-being for all of them. We also built fences in our legislation, and in a conference on integrated care, I think that is as well a subject that some of you have really a lot of expertise about. But if you are taking care of elderly, or if you are taking care of youth, or people with disabilities, or if you're working a social worker in well-being, most of the time you're limited to, okay, that's the group you have to take care of, and maybe in the same home there's somebody from another group, but then somebody else will have to come and take a look, because you can't do that. In a neighborhood approach, you will try and see how can we match those things together? How can we put the patient or the client center, and how can we match our services to that need? There's, of course, a very simple principle. To realize it in practice is much more difficult and takes some more efforts. But we also, and that's the last one where we put fences. In Belgium, we have quite a lot of governments. Maybe somebody told you that. But we also sometimes put fences in between those governments, federal and regional, but as well regional and local governments. And as well on that kind of level, we wanted to cooperate, and all our caring neighborhoods have their local government as a partner, so we can cooperate and work together. Here you can see only a few of the logos of the different organizations who we partner up with. Because we needed to listen to academics, we needed to listen to local governments, we needed to listen to the King Baldwin Foundation, who had experience, and we got them all together. As well as a lot of colleagues, and Isabel is one of them. Actually, yeah, she does most of the work for the Caring Neighborhood initiative. But as well, all of our colleagues in the different fields of our Flemish administration, we also brought them together to check, like, okay, which fences do we have, which regulations can be simplified so caring neighborhoods would be more possible, or which legislations should be adapted. By bringing all those partners together, we had a lot of knowledge to share and to use. But we had another big challenge ahead. making sure that when you're starting that kind of initiative, that you don't forget who it's about. And it's about the people living in those neighborhoods having big or small needs in care, in well-being, stuff like that. And how do we address, when we're sitting in our office in Flanders, how do we address those needs? Then we took a very important option, I think. We didn't say, this is the goal of every caring neighborhood. No, we said, okay, we have this vision, and now we will ask all this local projects to set their own goal based on an analysis of their neighborhood. What are the issues? Is it an old neighborhood with lots of older people in need of care, or is there an issue of loneliness, or do you have young families? The neighborhood here in Sint-Andries in Antwerp is very different than a neighborhood in a small village. So we asked them, what is your goal? What impact do you want, and how to measure that? And how to accomplish that? And to do that, we also give them some supports. We give them tools. We give them an inspiration session where they could listen to good practices from all around. We also decided that we would engage the King Baudouin Foundation so they could hire coaches. So the project will get immediate support. So actually, we tried to have a top-down vision where we were going to, but have a bottom-up approach on how to engage those local communities. And I must say, we started off well. We had a webinar with over 1,000 people, people interested in handing in projects, and in total it was a success. Here you see a small map of Flanders and Brussels, and you see 132 of those small hearts of our caring neighborhood initiatives. They're all working. The past few weeks we had 5 regional moments to learn from each other where we get them all together. We shared experiences, we shared as well some failures to see what can be learned and how can we address those. And that will be also for the next year one of our important challenges, to not leave those neighborhoods behind, not let 132, even if they're working bottom up, but not let them alone in their own community, but engage them and work with them. And I already thought about the coaches we have from the King Baudouin Foundation, but as well all those academics, all those experts from civil society. We didn't only invite them to listen to them, but we also engaged them and asked, do you want to cooperate? And actually you see here a picture of a 2-day meeting we had to determine which kind of coaching, which kind of expertise do those neighborhoods need. And you see a lot of professors, you see a lot of experts in their field, and actually we still have the possibility that when a neighborhood or some neighborhoods discover a problem, for example, we noticed that on the level of participation of some vulnerable groups, like people in poverty, people from another ethnic background, that was low. Well, we have expertise in our group to make actually an extra webinar to give people extra tools to address that kind of problem. And I must say I'm really grateful to all of them. What are some of the next steps? Another important thing is to keep all the stakeholders, like workers' federations, the federations of our institutions in health and care, federations of our local governments, to keep them in touch with the Caring Neighbourhood Initiative, to learn as well from how they experience it, to see what we can adopt. And for that reason, we will now start until from summer until start of 2024, to have as well some meetings with those stakeholders so they can implement caring neighborhoods in their regular work. We're also trying to break down our own fences in legislation. A lot of colleagues are working on that to determine which are the quick wins and which are the evolutions we should work on in legislation on the longer term. We will host as well a big conference in Brussels in 2024, where we would like to present the results of the projects we already have. We will also get the results of the toolbox, which Professor Verté is working on. She will later join you on stage. For starting caring neighborhoods, we're also looking how to share that on an international level. We would like to cooperate further with WHO. And to finish my speech, I will like to show you this picture. You see our minister who was here yesterday, but it was taken in Zonnebeke, in the small village called Zandvoorde in Zonnebeke. It's the west of Flanders. The community is best known for Passchendaele, which is also there, which is known for the Commonwealth graves during the First World War. But you have some very remote small towns, and in one of those small towns, nothing was there anymore. No services, no shops, no bars. Actually, people were just living there on their own in a rural community. Now the local government decided, okay, we will start a caring neighborhood. We will cooperate with neighborhood workers, and we start a meeting center in our town center. And what did they do there? People can come there, they have a coffee. They also installed a small shop where people can buy very basic groceries as well from the local farmers, so on durability it's quite well. And then they cooperated with an organization called the Lovi, who is working with people with disabilities. They're people that are opening, they're serving the coffee, they're helping people with their groceries. So for them, it's a nice, a real job they have. And from the people from the neighborhood, they come, they stay for an hour, they can talk with people, they can combat loneliness. But as well, local government is coming there every week to help people with their administration alongside a cup of coffee. And in that way, they actually really make the caring neighborhood what it's all about, like having people living in a more healthy, in a happier environment when they're old or when they're young, and making local networks. I will finish here. I hope I didn't exceed my time limit too much. If you want to remember something, I would like to sum up. First one is work together and break down fences. Second one, choose a bottom-up approach to answer really fundamental needs in society. Integrated care and well-being are the key to succeed, and involve all the partners you need and take them serious in every way. And never lose the focus on what we're doing it for, keeping the people in the center of our works. And a wise man from an Australian soap series once said, neighbors should be there for one another. That's when good neighbors become good friends. Thank you.
Thank you so much, Bert, for a wonderfully vivid presentation. I think all those pictures of people smiling, people participating, people living their best lives, that's what this is all about. So thank you for bringing that to life, and to really giving us a great introduction to our panelists. So if we could now invite our four panelists to come up and join Bert and Kira on the sofa, and we've got an opportunity to unpack the concepts that Dr. Fortune and Bert have begun to sketch for us, and get a sense of how these concepts are coming alive in different parts of Europe and beyond. So we will not introduce everyone right at the start. We'll take it one at a time. And really the rest of this session is about having a conversation with our panelists. We're all experts in the room. Our panelists have perhaps a little bit more lived experience than many of us in this topic, but the whole concept of compassionate communities and caring neighbourhoods is that everyone can act together. And it's my great pleasure to start the conversation with my friend and colleague Alison Bunce from Inverclyde in Scotland. Alison is a Queen's nurse, which is a very important role, a community nurse working at the heart of neighbourhoods, but also has a background in palliative medicine and in community development, and has combined all of those skills to lead what she calls Compassion Inverclyde in one of the most deprived areas in West Central Scotland. So Alison, it's great to have you with us. Can I just ask you to start by reflecting on what you've heard from Ciara and Bert? How does that land with you, and how does it compare and contrast with your experience?
Thank you for inviting me here, and it will be my great pleasure to share some of the work that we've been doing in Inverclyde in Scotland. And I sat down there listening to the speakers and just nodded my head the whole way, because it really resonated with everything that we're doing within Compassionate Inverclyde, especially around people. People and relationships are the most important thing that we have. I was at a session earlier this morning at 8 o'clock and about integrated care and people, and listening to what people have to say to shape care is just exactly what we did in Inverclyde to make Compassionate Inverclyde. Our slogan is ordinary people helping ordinary people. So yeah, breaking down the barriers, just like trying it out and seeing if something works instead of getting worked up about process and framework. But actually, if you've listened to the people and they've said, this is what we would like to try, and if it works, then that's great. And if it doesn't, then we just go back to the drawing board. And the other thing that resonated was around really involving as many stakeholders as possible to share the vision and not have outcomes at the very start, but have a clear vision. That was really what I heard and what resonated.
Mm-hmm. And Ciara talked very powerfully about health equity and inequalities. The area that you're working in is quite a socioeconomically challenged community. How has some of the work that you've been doing impacted on people's experience of equity?
So we have truly made our programme an organic programme. So we have taken on board the conversations that we had with members of the community. In every single group that was already established within Inverclyde. Inverclyde's quite a small area. It's a population of 80,000. And as Anne said, it is really deprived. So we wanted to make sure that in those initial conversations, we reached out to the people in the margins. The people who perhaps were in recovery, the people who were new Scots into our area, and we involved them in every single conversation in order that we were able to listen and to develop programmes that ranged right across the board. And one example of that was around No One Dies Alone. And so to put some background, I'm the only paid person within Compassionate Inverclyde, and every other person that I work with is a member of the community. So at the minute, I'm working alongside about 120 people in our local community to make all of the programmes work. And the No One Dies Alone is a beautiful example of how ordinary people can help ordinary people at a time that's really quite, emotionally charged. Perhaps a person's dying in the hospital or in their own home and they don't have any family or friends to visit. We can have someone sitting at the bedside in 20 minutes from one WhatsApp message. But the equality in all of that is that anyone can come along. If they have a good heart, anyone can get involved in that. And we have a diverse group of people who provide that service within our community. So that's an example, perhaps.
So that's a great example of acting at times of crisis and loss. What about earlier in the life cycle? What kind of work will you do with younger people or younger adults?
So we also developed a high five programme, which is universally the 5 key ways to well-being. And we took those themes and we developed a programme over 5 or 6 sessions and wrote lesson plans for schools, which really embraced their curriculum for excellence. So the schools took on board the 5 key ways to well-being with a big emphasis on kindness and the reciprocity of doing good things, because we really want, our vision for Inverclyde is to become really compassionate and really kind to one another. And the way that we can do that is starting with children in their education alongside everybody else in the community. That was certainly another example.
And I think, did I hear you right? You were saying you're doing something with new mums. What's that about?
So the person who leads breastfeeding in Scotland got in touch and said, I really like the way that your movement is not about structure, and we would like to work with you in a partnership to think about how we could best support new mums, especially at that time if their husband or partner are away or they don't have anyone at home and they've got this new baby and they feel a bit overwhelmed. So we have new mum companions who will go in and help that new mum just to help nurture the attachment with her baby, not to take over and feed or do anything like that, but perhaps wash dishes or play with another toddler or whatever, in ways that's meaningful to the person. And that's the most important thing in everything that we do. It has to have meaning for another person.
Okay. Well, thanks very much, Alison, for giving us such a great insight into the work that you've been leading in compassionate communities in Scotland. And I think it's fair to say it's not just Inverclyde. You're in great demand to sort of support other compassionate communities across Scotland and beyond. And I think now maybe we'll pass over to our next panellists, and Isabel will have a conversation with Sonia.
Yes, I'd like to have some other questions for another guest. Good morning, Sonia Hsiung. You're the director of the Canadian Institute for Social Prescribing, and welcome to our panel.
Thank you.
So Kira already mentioned the social determinants of health impacting lives, and social prescribing can address those social determinants. But can you tell us what is social prescribing exactly, and what are the key elements of social prescribing?
So social prescribing is a fairly new term that emerged out of the great work that UK has been doing over the last several years, but the concept should be quite familiar to most of us here. And it really is around putting in an intentional and structured way to connect the formal healthcare system with the social, voluntary, informal support, caring communities, and other networks that exist and are important for all of us to be well. So the idea is to leverage the healthcare provider as an important doorway to identify and recognize when someone has needs and goals that goes beyond what can be supported in medical care, and connect them to those resources in the community in a way that is person-centered, is co-created, and is supported by a particular dedicated point person. And that person has many names. In the UK, they're known as link workers. In Canada, we often call them community connectors or navigators of well-being. In other places, they could be community health workers. But this is the person that journeys alongside, supports the person to connect with those resources that supports their social determinants of health. And it's not a new concept, but in Canada, we are seeing a tremendous momentum around this because it offers a very accessible term and a common language for us to align and name all of the types of practices that are very similar, and for us to do this type of work and to measure this in a structured and intentional way. So for us, we're seeing this as quite an important way for us to bridge healthcare and community and to advance integrated care. It's part of the tool in the toolbox.
I can see that we could have a lot of impact with social prescribing, that we could work in a preventative way, non-medical also, which is also already also new. We mentioned it already a few times in this panel, the concern to leave no one behind, the concern for health inequity. We also spoke with Alison of her neighbourhood, which is a neighbourhood with people with a socioeconomic more difficult background. And isn't that a concern then when we talk about social prescribing? Doesn't it require a lot of social skills of people? And so is it an adequate method to use or to get to those vulnerable people?
That's a fantastic question, Isabel. The beauty with social prescribing is precisely that it reaches the people who are disconnected from the system. It catches people wherever they are, and our focus are the people who are not able or not willing to connect with or access the resources in the community for a variety of reasons, and some very good reasons. In Canada, most of our projects are focused on people who are facing barriers to health and well-being. So for us, and as other panelists have already mentioned, that includes people with lower income. For us, that's newcomers, also people who are on different places in the gender identity and also have various sexual orientations. That could include for us Black and racialized populations, and as well, of course, frail and isolated older adults. So the connector journeys along with the person. They're helping to address barriers along the way, and at the same time, the goal is to build and affirm people's capacities to take control of their own health and well-being so that they can engage with and navigate with the systems themselves eventually. So absolutely, for us, this is a way for us to address health equity and to reach the people who are vulnerable and disenfranchised in our communities.
You mentioned working with people. You also mentioned barriers. Bert also mentioned barriers before, and I noted that he said we have to work together, break down fences, put people in the center of your work. Could you share more about what co-production would be like in social prescribing?
Yes, co-production, along with that journeying with people, for me is really what separates social prescribing from information referral or systems navigation or other types of navigation that we often see. So on the one level, there is that co-production between communities and organizations, so that systems level connection and integration, talking to each other, communicate, and bridging services. But at another level, which is what I think Bert and Alison has talked about in their initiatives, is recognizing that people are more than the sum of their illnesses or their medical diagnosis. They have histories, they have goals, like we heard yesterday from those great panelists, and they have gifts to contribute. So part of social prescribing is inviting people in to, and supporting them to contribute their gifts in that way when it's appropriate. So in many of our communities that are more rural or remote, we don't have a lot of formal community services or maybe supports that are in place. And in some of our urban regions, we have very long wait lists, and in some places, just the appropriate services for particular populations simply doesn't exist. But when we are co-producing with people at the center, with the gifts of people who are invited in to be leaders and peer supporters, that's when we have seen new services and new innovations happen, which I think is very much aligned with the approach in Caring Neighborhoods. And in fact, we have seen the biggest change in health outcomes when people are supported and invited to contribute in this way. So we see increased sense of purpose, sense of confidence, fulfillment in their life, and their sense of belonging to their communities. So that co-production piece for us is what shifts the power dynamic between patient, community, and health systems in those traditional roles, and is the transformative power of social prescribing.
Maybe one last question, just out of curiosity. So what are the next steps you're going to take to scale this up? You already took some steps on the path to social prescribing. And maybe, as I also work for a government administration, is there interest from government decision makers? And I think it was also a question out of someone of the audience, what could be the role of a government in this? So is there interest of the government?
Well, absolutely. There's a huge role of government. Now, in Canada, we are quite unique in that we are a very large country. We have 10 provinces, 3 territories, and our health care systems are governed individually, separately in those provinces and territories. So we have some challenges to scaling something that is of a national approach, but there is significant interest, I would say fantastic conversations, and a lot of forward momentum with many of our health system leaders, as well as health authorities in different regions. You know, as people have mentioned, COVID has really shone a light on our need to support people's social needs, and our healthcare system and our community support systems are stretched to the limit. So there is a window of opportunity here for new approaches, and there is a significant role of government to support the resourcing, support the conversation, and support the convening of this type of work. Now, for us, we look at with envy to our colleagues in the UK, where they have seen significant government investment into the role of link workers, into resourcing the workforce that is necessary to support this type of work. In Canada, we're taking a bottom-up approach. So at the Canadian Institute for Social Prescribing, at the Canadian Red Cross, very much embodying the principles of this work, we have invited and gathered partners from different sectors, as well as people with lived experiences, to help us design together what a national framework for this would look like for us, in a way that still holds that equity, that community leadership, as well as that spirit of collaboration. So that's the journey that we are on, and we look to our international partners, we look for other very similar and aligned and complementary work to continue our approach in embedding social prescribing as part of the integrated care systems that we want to move forward.
Thank you so much. I already discovered the website of your institute, and I will be eager to follow the next steps you're going to take on social prescribing. Please. So thank you very much for this interview.
Thank you. And to continue that conversation about social prescribing, it's impossible to talk about social prescribing without talking about family medicine and primary care. So it's my great pleasure to welcome Professor Emily Verte, who's founder of and chair of the Primary Care Academy in Flanders and works with the Department of Family Medicine and Chronic Care. And I wonder, Emily, how do you see the role of primary care in contributing to social prescribing and contributing really to the goals of population health and integrated care?
Thanks a lot, Anne. First of all, I'm not the only founder for the Primary Care Academy. We did that with a bunch of people, around 60, so I'm one of them. Yeah, primary care providers are really the care providers that are present in that local community. So they have the closest connection, the closest relationship with the population that is living in those local communities, in those neighborhoods. So they see those people, they meet them, they are the first to see something and to detect something. So they are having a real they have a real value in signaling. So they are very important in detecting those who are undetected, those primary care providers. Yeah, and then on the other hand, you have that bond, that trust that is going on, that you have a little bit less on higher levels, more specific into the cure sector. So that is, I think, the real value of primary care providers. And we are with a bunch of them, primary care providers. So it's not only the medical providers, they are social workers, you have the physiotherapists, you have the psychologists. It's just, yeah, I cannot name them all. There are so many of them. So yeah.
No, absolutely, that interdisciplinary team working at a neighbourhood level is the beating heart, really, of integrated care. How do you prepare professionals, the future generations of primary care clinicians and practitioners to work in a different way, to embrace co-production, to support shared decision making? What's the secret?
Yeah, that's a very good question, Anne, because today that is exactly one of the reasons we founded the Primary Care Academy. So we are a network with a lot of disciplines, transdisciplinary research and education, not only for the basic trainings, but also for the lifelong learning perspective. So that is why we founded the Primary Care Academy, and that is what we all, with that whole network, we all saw and felt that we should do something about that we have to innovate our education as well, that we have to develop interprofessional education for some sort of universal curricula for the whole primary care profession of the future. So that is something that we are looking into at the moment with our Primary Care Academy. We have some steps to go in the development. We're not there yet because it's not that easy to change curricula because it's very dependent on the institution itself, and we have a lot of institutions here in Belgium, which is great, but change doesn't come overnight, right? So it's certainly not that easy, but we have a lot of opportunities today, and we are grabbing those.
Absolutely. You're right, culture change takes time, and it also is very heavily influenced by different context. Have you observed any difference between rural and urban neighbourhoods and the role of primary care in those different contexts?
Yeah, I do not like to speak about rural and urban context as such, because everything depends on the neighborhood. Mm-hmm. And not really the rural or urban. It depends on the neighborhood itself, how it's developed, and the people who live in that neighborhood. So it depends on the presence of amenities and services. It depends on the people who live there. So it's not really dependent on rural or urban settings. So it really, we see in research that it truly is dependent on that local context as such. So and there are so many differerences between neighborhoods. So we cannot draw a line there. Nevertheless, what we heard already, we always talk about the prime neighborhoods and a lot of the place-based approaches, and that is truly one of the features, the core features of primary care as well, and caring neighborhoods. But it's also about the capacities, right? It's also about the assets that are living there. And we heard it of Alison. You really work with those capacities, and I think that is very much the value of also primary care in the future, to combine the professional capacities with those informal capacities. And it is not there, we are not there yet, but some, I think here in Flanders and in Belgium, some link workers would be great, or a huge investment in link workers would be great, to really support that change and really move forward more rapidly, I would say, yeah.
So there's a call to government, call to regional government for investment in more link workers. Let's all get behind that. So thank you very much, Emily, for your contribution. And I'll maybe hand over to Isabel for our last conversation.
So last but not least, good morning, Professor Liesbeth de Donder. You're a professor in adult education services at the Vrije Universiteit, Brussel. Welcome. And professor amongst caring neighbourhoods, you have years of experience in aging in place and compassionate communities. We talked already a bit on those compassionate communities, but we cannot talk about a caring neighbourhood or a compassionate community without talking about aging in place. And we already heard some examples here today in the Healthy Cities Network mentioned by Kira. But what do you understand exactly under aging in place?
Okay, thank you, Isabel, also for inviting me to the panel. Aging in place, a concept born 20, 30, almost 40 years ago, and has been on the agenda of policymakers in Belgium, internationally, since 2000, let's say, and in some countries even since the end of the 80s. And throughout the years, we have preferred to talk not about aging in place, but about aging well in the right place. And let me explain you why we talk about aging well in the right place. If you would go to one of the earliest definitions people have been using, and one of them is, for example, from the WHO, and I've been going in my notes on my computer to see what was one of the most original ones I've been using. And in the early 2000s, there was a glossary of the WHO, and aging in place was in the glossary list. And in the definition, it was written that aging in place concerns living in the own house, the own home, or in the neighborhood, or in an adapted form of housing. And throughout the years, I see that it starts living an own life. That happens with concepts. It starts living own lives. And it has been narrowed down to living in the own house, and then people add as long as possible. But for me, aging in place is more than just aging in the own house. It's about aging well. That's the goal. Aging in place can be a mean to age well, but it's not the goal as such. And sometimes I see that people confuse the goal and the means. And it's for me about aging in the right place. And often that could be the own house. There's a strong desire of older people to keep living in their own house, and that's good if it's possible, and it's if the house is of sufficient quality. But we also see that sometimes older people's houses are not of sufficient quality, are not good enough to age well. And so it could be the own house, but it could also be moving somewhere else in the neighborhood. It could be moving to a smaller apartment and not living in the big house. You've raised your 4 children maybe, and you have a big garden. It could be about moving to a nursing home. Because in that original definition of the WHO, the last sentence was, the goal of aging in place is delaying the traumatic move to a residential nursing home. And I think often that sentence, that's good now, that people are also forgetting that, or looking critically at it, because I don't like the opposition or living at home or in a nursing home. And I really, the sentence, a traumatic move to a residential care facility is really putting the discourse or the narrative that nursing homes are not good, are not providing quality of life. And maybe some nursing homes still have room for improvement, let's say. But we also know about really good residential care facilities. And so aging in place is for me about aging well in the right place. And aging well is actually the main goal.
It might be a wrong question to ask you now, given what you told me, Professor, but I'm going to ask you the question anyway, because I get it so often myself as I work for the Department of Care. And very often people ask me, Isabel, is it wise from the government, is it a good strategy to encourage aging in place, or should we encourage people with significant care needs to go to residential homes?
It's about having options. It's about, now it's like, or you age at home, or it's the residential care facility, and it's like the one or the other. And you, like say, you have to move to a care home at one point. After a fall, you end up in a hospital, and then you can't go home anymore, and then you have to go. And then it's often that you have to go, which is, of course, something I would like to get out of the narrative, get out of how people think. And it's about having your own house, it's about having smaller houses, it's about having co-housing, it's about having senior apartments, it's about assisted care facilities, it's about residential care homes, big, small, but it's about having choice.
I do remember aging well in the right place, I will never forget. So if we want to further engage in aging well in the right place, we'll also have to engage in caring neighbourhoods that include a focus on illness and grief. We already started with an example of Scotland, compassionate communities. Now you've done some research on compassionate communities also. Could you describe in general what is a compassionate community about?
At our university, we have a center of expertise, a compassionate community center of expertise. And actually, we've done that together with the end-of-life care group at a university, who's really focused on palliative care. And I always see it as us coming together. So we were working on aging in place, about people living longer in the community. At one point, they need help, they need care, so we have the caring neighborhoods. And then you had the group of end-of-life care who are working a lot on palliative care. And we have palliative care in hospitals. And we have palliative care in specific units where it's like, let's say, like in nursing homes, specialized units somewhere apart from the community. And they're moving and then thinking we need also think about palliative care in the community. And at one point we came together because you cannot think about aging in place without thinking about dying in place. And that's for me where caring neighborhoods could think about more. In the projects we have been studying or been seeing, and there's lots of attention on what we call low care or small help, and that's really great. Neighbors helping each other, looking out, visiting each other, mowing each other's lawn, going to the shop and bringing something for your neighbor. So that's really great. But at one point in life, people become more ill. They have more complex care needs. And then the question, do we also keep them living, aging in the neighborhood with complex care needs? And do we die in the neighborhood? So that the idea about you cannot think about aging in place without thinking about dying in place. And I see in the projects in Belgium, the 132 projects, several communities, several neighborhoods are picking up that idea and are really also thinking about death, dying, loss, grief, and I think that's really worthwhile.
Would it be correct to say that it's about introducing a caring attitude in general in a caring neighborhood?
At one point, I would say yes. And then I'm afraid that it will be misused, let's say, the message that caring neighborhoods is about caring attitudes. Something I'm always saying is caring neighborhoods is more than caring neighbors. It's not about, it's important that neighbors have a caring attitudes, help each other, see each other, value each other, connect with each other. And that's very worthwhile, but it's more than caring neighbors. It's about equity, it's about access to care, and we can't leave, let me say it like it is, ill-functioning government care provision up to care neighbors to solve structural and systemic flaws in our system.
You just mentioned also the health inequalities. That may be one last question I would like to ask you before we go to the full panel again. You also mentioned that an adapted home is also very important when we talk about aging well in the right place. But is it then a viable option for everyone, or and so even for people who are less wealthy?
There is a difference in your question. Is it a viable option, or should it be a viable option? And in Belgium, in our constitution, we have Article 23, which says people are entitled, have the right to humane life with decent housing. So not just housing, people are entitled to decent housing. People have the right to decent housing, but a lot of people don't have access to decent housing. So it's about a right, and we are having, I think it's the same idea as my statement before. It's about our government also working to provide and give people what they are entitled to.
Thank you very much for your considerations, Professor. And I think we'll have to conclude our interview here. But we go to the full panel again, so we can discuss more on this topic, of course.
Yeah. So I'm going to bring in some questions that we've had online. It's great that people are interacting. And maybe this is a question for Bert. Bert, there's a reflection that responsibility and accountability often divide governments between, national, regional, local government levels. So what can governments do at those levels to break down some of those fences and actually get out of the way and create the conditions for the good stuff to happen?
Well, some people will write the big books about that on how to organize, but I think as well my colleague in Canada mentioned as well that they have a system with national and regional governments that are taking care of the health system here in Belgium as well. For example, most of the health care is on the national level, prevention and well-being, elderly care is on a regional level. But I think foremost, and that's the same actually on the neighborhood level as on the political level, you need to have the will to cooperate and to talk about the plans you have on each level. And for example, on integrated care, we do have federal projects from the federal minister, and we have our caring neighborhoods, which is not the same thing, but they're related. Well, then it's good to know each other and to see, and then you go to the third level, the local level, how to implement them together. And I think, for example, in the city of Leuven, we have caring neighborhoods and we have those projects on integrated care. But because the players on the local level are the same people who are like in the primary care zone in Leuven, they can implement them together. But sometimes you will also get to bigger political questions on state reform and stuff like that. But I think that will lead us quite far in this discussion. But I think as well, if we ask it for people in formal care to work together, or if we ask formal and informal care to work together, we should look at ourselves and also think, we should also work together sometimes.
Thank you.
There was also a question here about of the public on compassionate communities, and if it would be necessary to give some formations to neighbors who are active in compassionate communities. Maybe Alison, and it might be a question for you. Do neighbors need that?
It's training?
Trainings?
I think in some level, then training might be useful if there was a particular need in like providing end-of-life care as part of an informal network supporting health professionals to do their job. Then obviously training would be beneficial for that. But I think from a neighbourly point of view, being kind and doing kind actions is something that we like to do without needing any formal training, that can make a huge difference to someone, like putting someone's bins out or just looking out to see that if someone has opened their blinds or whatever. So I think basic kindness is there as well.
Mm-hmm.
And there's a couple of comments about digitally enabling communities to be connected and compassionate and caring. Can I ask Kira, do you have any experience globally of the use of digital solutions to enable healthy and kind and caring cities?
Yes, certainly. So I think during COVID-19, I had the privilege of working in the Western Pacific region, and there was some very heavy lockdowns where, of course, it happened globally, but children under the age of 17, they were not allowed out in the public space. And I think that's where we saw that, technology really played a key role. But again, I think it's important and we saw that with older adults initiative as well, and we saw how the communities came together to, again, really address social isolation. At the same time, we also saw that there was a gap, and we saw that some of those inequalities also widened, because, for instance, in the Philippines, where you have high rates of poverty, there were many school children who could no longer go to school and who did not have access to technology. So it can be a true enabler, but I think there are challenges around that as well that we need to be aware of. But certainly I think there are many initiatives that we can, again, celebrate.
Yeah. And connected with that, there's also a question around information sharing, information governance, particularly between statutory providers and community supports. I wonder if Sonia or Emily have any experience of ways around that information governance to share data.
I have no answers for you, but I think it is absolutely something we are all actively looking at, because it is a significant challenge, and it is a challenge for us to then understand the value of community and value of the informal care networks, because we cannot track the data in the same way and the same rigor that we tend to do with health data. People have found creative solutions. There are also new innovations and social enterprises in Canada that is looking at this type of integration, but this is where we could really use the help of governments and our health institutions in helping to fill and address some of those gaps. But that is definitely a big challenge that we are dealing with.
Yes, and here I think in Flanders, one of the first steps of caring neighborhoods is doing some kind of, let's put it in market research, or look at the numbers from a population health perspective. And then you need access to those numbers on a neighborhood level, on street level sometimes. And today that's not accessible. So I think one of the next steps in policy here that I would love to support is access for everybody, also the citizens, so you can have a bigger share of power also for the citizens at the table. So because the power relations aren't equal, And if you want that change, if you really want to have an inclusive healthcare system, then you have to have equal power. And I think the numbers, access to data, really helps. And then some support, not only providing that data system, but also some support of managing it or I don't know, reviewing it or using it for your own good. I think that would also be beneficial.
Then there's another interesting question here on medicalizing social matters. And the question is, access to general practice is becoming increasingly challenging for people. So are they the best gatekeepers to social prescribing? And are we over-medicalizing a social matter?
Get this question a lot. So we have people who think this is too medical, and people who think this is too social. So it's yes and. So we're leveraging healthcare providers because, as Emily said, they are trusted people in the community where you have access to them for a lot of the population. Not everyone, but they are, for some, the trusted community. So they are one doorway. They are not the only doorway. We recognize there are other doorways that happen informally and formally in the community, and that is also important to recognize and be connected. But oftentimes, there are people who only access the healthcare system and nothing else, and they access it for their social needs, and those are the people that are falling through the gaps, and that where our health systems, primary care, emergency, community paramedics, and other health providers in the community can play a really important role in helping to identify and connect. And moving the people from the medical system into the social and community networks.
Yeah, great. So shifting power is really important, and data is power. But there's a bit of a conversation online about wonderful that this is it ambitious enough? Are we doing enough to actually shift power and funding and budgets? And Bert, any plans for participatory budgeting or something that's a bit more radical in terms of really shifting the power?
Well, those are some, of course, some important questions, and those are also questions which touch on things like state reform. If in our regions we do well on prevention, then healthcare will save money, but that's federal, and so on a budget level, that's a problem. If people are helped, that's not a problem, of course. So, but I think shifting budgets more towards local communities, that's been happening for the past 2 decades. Some people will say not enough, others will say it's been a bit too much. But that's something that governments are moving. But as well, to a lot of our institutions, we have a lot of well-being healthcare institutions which are non-profit or profit in private hands. They also have their budget, and they can not spend it whatever they want, but they can also make choices. And like our Caring Neighbourhood initiative also wants to encourage those people working in all those institutions to make choices, and to also think about maybe we can organize our work in a different way, because that's always the different. Change takes some time, and then getting some impulse can help to make that change in the way you do your everyday work.
Great. So there's still lots to do. We've covered a lot this morning in the session. I've learned a lot from our panelists, our presenters, and it's been a great conversation online, so thanks everyone who's engaged. On reflection, I can see in front of the wonderful smiling faces that Bert showed us of Caring Neighbourhoods is all about people. It's about people who live in homes, families, social networks, not in services, not in pathways. It's about supporting them to live their best lives. And I'm also thinking about IFIC's 9 pillars. As we've gone through the session this morning, I can see so many of the 9 pillars being unpacked when we talk about leadership, government leadership, professional leadership, creating new alliances, alliances that value people as partners in care. So I'm going to go back and reread that 9 Pillars document and think about caring neighbourhoods in the context of our 9 pillars. And I'm going to advertise the rest of the sessions around caring neighbourhoods. There's still more today, tomorrow. And also a plug for the long-term care empowerment model that we're going to hear about in the lunchtime session today with Liesbeth. More about ageing well in place. Isabel, would you like to close the session?
Well, I'd like to welcome you at the workshop if you want to, at 4:30 this afternoon, if you want to learn more or hear more about the building blocks. And of course, in that workshop, we would also like to hear you and your examples, because as Kira said, we would like to hear and learn from other regions, other countries, and so we'd like to exchange information in those workshops, and that can be very helping. Thank you, everyone, for your questions online, and thank you, speakers, panelists, for the interesting interviews we could have with you. Thank you very much.